Hello everybody and welcome back to Synapse. This is Ritika and in this video I shall talk about rheumatic fever. It is immunologically mediated multi-system inflammatory disease following group A beta hemolytic streptococci infection, usually pharyngitis, or could also be other infections like skin infection. The first thing I want to address in this video is the difference between rheumatic fever and rheumatic heart disease. Though these two terms are commonly interchangeably used, there is some difference between the two. Rheumatic heart disease, it is the cardiac manifestations seen in rheumatic fever. While rheumatic fever includes the manifestations of in heart, neurological manifestations, skin, and joint manifestations. Though the incidence of rheumatic fever is declining in the Western world, it is still a public health problem in developing countries. Let us now look at the pathogenesis. Rheumatic fever is a hypersensitivity reaction caused by antibodies directed against group A streptococcal molecules, mainly M protein, which cross reacts with the host antigens, namely cardiac myosin and sarcolemmal membrane proteins, and causes inflammation, and thus causing the manifestations. Let us now look at the Jones criteria for diagnosis of rheumatic fever. We have five major criteria and some minor criteria. Major criteria include Sydenham chorea, carditis, which is now considered as subclinical carditis 2, erythema marginatum, subcutaneous nodules, migratory polyarthritis. Among minor criteria, we have fever, raised erythrocyte sedimentation rate, raised C reactive protein, arthralgia, and first degree AV block. For diagnosis of rheumatic fever, we need two major criteria or one major with two minor criteria, or if the patient has previous history of rheumatic fever, that is if this is recurrence of rheumatic fever, then three minor criteria are enough for diagnosis. This image, I shall upload this image on our Instagram page at Learn Synapse. Do follow our page if you do not already follow. You can use this image for in your notes. You can use this for a quick revision. Anything, the access is on our Instagram page. Let us now look at each of these criteria in detail. Talking about carditis. Earlier, under Jones criteria, carditis meant endocarditis, valvulitis, myocarditis, or pericarditis. But under the modified Jones criteria, now, even subclinical carditis is considered as a major criteria, which can be diagnosed by just echocardiography. Before we talk about the clinical features of carditis, let us look at the histology of Ashkoff nodules. Ashkoff nodules are pathognomonic for rheumatic fever, but these are seen in acute phase of the rheumatic fever and not in the chronic phase. In chronic phase, the Ashkoff nodules are replaced by fibrosis. These Ashkoff nodules consists of collection of lymphocytes, scattered plasma cells, and plump activated macrophages called the Anichko cells, which is marked in this diagram. These Anichko cells has this nucleus in the center arranged like a caterpillar, and so these cells are also called as the caterpillar cells. If there is pericarditis, then the patient would complain of chest pain at rest. Friction rub can be heard on auscultation, and this friction rub can be heard even after the patient holds his breath. And this is how you differentiate the friction rub as that of pericarditis versus that of pleuritis. In case of myocarditis, there could be congestive heart failure, pulmonary edema. Valvulitis is a very important component of rheumatic heart disease. Mitral valve is very commonly affected, although aortic valve can also be affected. In acute phase of rheumatic heart disease, vegetations are seen on the closing end of the valve leaflets, as shown in the diagram. This might lead to some regurgitant flow, leading to mitral regurgitation, where there is a pansystolic murmur heard and a soft S1, heart sound 1. As the disease progresses to become chronic, there can be fusion of the commissural ends of the valve leaflets.
which might eventually lead to mitral stenosis. The fusion of commissural ends can lead to an appearance called as the fish mouth appearance as seen in the image. In mitral stenosis, there is mid-diastolic murmur with a presystolic accentuation and loud opening snap. There could also be McCallum's patches seen in the left atrium, which is because of the regurgitant blood hitting onto the endocardium over a period of time. Initially, only a flow murmur is heard, and this flow murmur is called as the Carey-Coombe murmur, which is a mid-diastolic murmur. Although as the disease progresses, there could be other murmur as mentioned in mitral regurgitation, mitral stenosis. There could also be aortic regurgitation in this patient. And I want you to remember that if a young child has aortic regurgitation, a very possible cause for this is rheumatic heart disease.
Talking about arthritis, it is one of the earliest manifestations in rheumatic fever. And this is migratory polyarthritis. That is, the patient has pain or arthritis in multiple joints, one after the other. And this arthritis characteristically reduces with aspirin. Sydenham chorea. It is involuntary regular movement at the distal joints of hand. It is a late manifestation, and Sydenham chorea is because of damage to caudate nucleus. On examination, you will find darting tongue, which means when you ask the child to protrude his or her tongue out, it rattles like that of snake. Hung up reflexes, meaning when you check for deep tendon reflexes, the contraction phase of the muscles lasts longer than normal. Milkmaid sign is where when you ask the child to flex his fingers around your finger, there is continuous waxing and waning of the strength of contraction or strength of flexing. That is milkmaid sign. This is usually self-limiting, but sometimes it might need medical intervention with valproate, haloperidol, or even steroids. If it is medically refractory, then you would want to give intravenous immunoglobulins. Subcutaneous nodules is also one of the major criteria in Jones criteria, which is non-tender and is seen commonly on the extensor surfaces, usually on the olecranon process. Erythema marginatum is another major criteria. Where these rashes, as in this image, are seen, there's central clearing, which leaves a red margin to these rashes, and thus they're called as erythema marginatum. The best investigation would be to look for raised anti-streptolysin O antibody titer or raised anti-DNase B antibody titer. And about the treatment, aspirin can be given for arthritis, as already mentioned. Steroids can be used for cardiac and neurological manifestations. Valproate for chorea, intravenous immunoglobulin for medically refractory chorea, and benzathine penicillin must be given at the dose of 1.2 million units every month until the age of 21 years. And if the child has already developed valvular defects, then you'll have to continue this benzathine penicillin until the age of 40 years. This is a simple overview of the treatment. There could also be a need for surgical correction if the disease has progressed a lot. This is just an overview of treatment. So here I end the topic of rheumatic fever, and I hope you found this video helpful. If you did, like the video and share this, and subscribe to our channel if you haven't already. Check out our Instagram page at Learn Synapse, where you can get access to certain images that will help you revise topics easier, and also there are questions on our page. You could try and solve them. Thank you and bye-bye.